Hello and welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the GP Notebook study group presenters. And in this podcast, I'll be discussing polymyalgia rheumatica, or PMR, hopefully in a way that sits closer to our real clinical practice than textbook descriptions. Now, it's a condition that most of us recognise fairly quickly once we've seen a few cases, but the subtleties matter a great deal, particularly with the overlap with giant cell arteritis, the interpretation of inflammatory markers, and the long-term steroid strategy that follows the initial diagnosis. Now, at this point, I think it's useful to frame the condition properly. PMR is fundamentally an inflammatory syndrome driven by immune dysregulation rather than a structural musculoskeletal disease as such, and we still don't have a single unifying cause. Instead, it does appear to sit at the intersection of genetic susceptibility, immune activation, and even possibly environmental triggers. Now, we do know there's a consistent association with certain HLA class II alleles, particularly HLA-DRB1 variants, which suggest an underlying antigen presentation component. But beyond that, what we actually see clinically is an inflammatory cytokine-driven process. So let's begin with the patient journey, because that's usually where the diagnostic clue sits. The incidence of PMR increases with age, typically occurring in those older than 50 and rarely in younger individuals. And the typical patient presents with something that sounds deceptively simple: aching and stiffness. But when you explore it, the story becomes much more specific. They're not describing isolated joint pain in the way you might hear in osteoarthritis, for example. Instead, they describe a profound stiffness centered around their shoulders, necks, and hips. And many will say things like, "I feel I've seized up overnight," or "I can't lift my arms to do basic things anymore," or "I'm really struggling to comb my hair." One of the most characteristic features of PMR is how quickly this develops. It isn't a slow burn over months or years. It often evolves over days to a couple of weeks, which is part of what makes it so striking in primary care. And the functional impact is often disproportionate to what you might find on examination. Patients struggle with dressing, particularly with tasks such as lifting their arms overhead or reaching behind their back. And simple activities like getting out of bed, standing from a chair, or fastening their clothing can become unexpectedly difficult. Now, that functional limitation is often more important than the pain itself. Many patients don't actually describe sharp pain so much as a deep aching stiffness, worse in the morning and after periods of rest. They often improve as the day progresses, only to stiffen up again if they sit still for too long. And that pattern of morning predominant stiffness with partial improvement on movement is a key clinical clue in my experience. Now, alongside these musculoskeletal symptoms, there's frequently a systemic component, so fatigue is extremely common here, and sometimes profound enough that patients describe it as overwhelming or even flu-like but persistent. Some patients can experience low mood, reduced appetite, and weight loss, and a low-grade fever can occur, but anything more significant than this should immediately broaden your differential, particularly towards infection or a large vessel vasculitis. Symptoms suggestive of giant cell arteritis include unilateral, temporal or occipital headaches, scalp tenderness, jaw claudication, or visual symptoms. Now, if we move on to examination of these patients, there's often an interesting mismatch between patient-reported disability and objective findings, and patients frequently describe weakness, but true muscle strength is usually preserved. What limits their movement is pain and stiffness rather than neuromuscular impairment. So, patients may exhibit a limited range of active movement of the shoulders and hips due to pain and stiffness, and may have difficulty rising from a chair or the examination couch. There can be muscle tenderness of the shoulder and hip regions, subacromial bursitis of the shoulders, trochanteric bursitis of the hips, and occasionally an oligoarthritis of the peripheral joints. And on occasion, I've even seen swelling of the fingers and dorsal surfaces of the hands and feet as a result of tenosynovitis. Always check for oral ulcers, rashes, cardiopulmonary abnormalities, abdominal abnormalities, and focal neurological findings. And I would always assess for signs of giant cell arteritis, such as temporal and occipital artery thickening, nodules and tenderness, as well as scalp tenderness. The reason I do this is because around 15 to 20% of patients with PMR will go on to develop giant cell arteritis at some point, and a significant proportion of these will report preceding or concurrent polymyalgic symptoms. So when you diagnose PMR, you are never managing it in isolation. You're always also actively screening for an evolving vasculitis. An elevated ESR or CRP levels are supportive in the settings of characteristic history and examination findings, but I think it's important to say here that normal values in the setting of a characteristic history and examination findings do not rule out the diagnosis, because rarely PMR can present with normal markers of systemic inflammation. In fact, a normal ESR or CRP in patients with PMR may actually indicate a milder subset of the disease, or the patient is early on in their disease course. Autoantibodies such as rheumatoid factor and anti-CCP are generally negative, and this helps to exclude rheumatoid arthritis, although seronegative disease always requires clinical judgment. In patients where their shoulder and hip pain predominate, myositis should be considered in the differential, and a creatine phosphokinase level checked accordingly. Now, imaging here has become increasingly helpful, particularly when the diagnosis isn't entirely straightforward. Ultrasound, for example, can demonstrate subacromial or subdeltoid bursitis, biceps tenosynovitis, or synovitis in the shoulder and hip regions. Now, these findings aren't specific in isolation, but in the correct clinical context, they strengthen the diagnosis considerably. MRI scans provide more anatomical detail, particularly around the pelvis and hips, and can show peritendinous inflammation that correlates well with symptoms, but the presence of symmetric shoulder and or hip arthritis in the absence of a bursitis or tenosynovitis would be more suggestive of a systemic arthritis such as rheumatoid. Now, once the diagnosis is established, treatment is usually very effective, which is both reassuring but slightly deceptive. Corticosteroids remain the cornerstone of therapy here, and the response, as we all know, is often dramatic. Patients frequently report very significant improvement within 48 to 72 hours, sometimes describing it as feeling like their old selves again after weeks or months of impairment. However, an incomplete response to low-dose corticosteroids doesn't actually rule out the diagnosis. So this rapid response is clinically useful, but it shouldn't be mistaken for a cure. What it is symptom control in a chronic inflammatory condition that typically requires months of management. The initial doses of prednisolone are usually in the range of 12.5 to 25 milligrams a day, tailored to severity and patient factors, and the dose should be increased until there is complete symptom resolution and normalization of the ESR and CRP. Now, once symptoms have resolved and the inflammatory markers have normalized, the dose is then tapered, and this can be a real challenge. The goal here is to reduce steroid exposure while maintaining disease control, but too rapid a reduction in steroids often leads to relapse, and relapses are common, with an average relapse rate of over 40% at 1 year. Now, these should be managed by increasing the dose of prednisolone to back the pre-relapse dose again, and then reducing after 4 to 8 weeks. The average duration of treatment is up to 2 years, but a quarter of patients require treatment for more than 4 years. Non-steroidals aren't recommended for the treatment of PMR, and in all adults over the age of 40 taking prednisolone above the dose of 2.5 milligrams a day for over 3 months, prophylaxis of corticosteroid-induced osteoporosis is recommended with calcium and vitamin D supplementation. And this is also where steroid-sparing agents become important. And methotrexate is the most commonly used adjunct in patients here at higher risk of relapse or in those who develop steroid-related complications. Now, when methotrexate is used as a corticosteroid-sparing agent, it should be continued until the steroids can be tapered without the recurrence of PMR symptoms. But there are no definitive guidelines here regarding the tapering of methotrexate. However, once steroids have been successfully tapered, it's entirely reasonable to discontinue the methotrexate by tapering the dose over about 3 months. Monitoring should always be ongoing and structured, and early follow-up is frequent, often every few weeks initially, and then gradually spaced out as stability is achieved and symptoms remain central to the assessment. Inflammatory markers should provide supportive information here rather than driving clinical decisions in isolation. Now, despite these challenges, the overall prognosis of PMR is good. It isn't associated with increased mortality when it's managed appropriately, and most patients do eventually achieve remission, although the timeline can vary considerably. And as I say, treatment is typically required for 2 to 3 years or so. An increased risk of relapse or prolonged therapy has been shown to be associated with being female, having an ESR above 40, and having a peripheral arthritis at diagnosis. If giant cell arteritis is present, then the prognosis and treatment is directly related to this condition rather than PMR. So, the key clinical message here is that PMR isn't just a musculoskeletal condition. It's a systemic inflammatory syndrome in older adults with a very specific pattern, a strong therapeutic response to steroids, and a critical association with giant cell arteritis that must always remain in our mind. Every follow-up visit is therefore doing 2 things at once. We're tracking response to therapy, and we're quietly reassessing for features that might suggest a shift into a more dangerous vascular process. And this dual focus is what makes the condition straightforward in treatment, but nuanced in practice, in my view. So that's a very quick overview of polymyalgia rheumatica, and I do hope you found this podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.